Hello and welcome to today's Connecticut Women's Consortium webinar, Adolescent A-SBIRT. It's my pleasure to introduce your speakers for today. Nova Comisar, BA in Psychology, is an administrative training specialist at the Connecticut Women's Consortium and a certified A-SBIRT trainer. Kathleen Callahan, BS in Computer Engineering, is the Trauma and Gender Coordinator at the Connecticut Women's Consortium. She's currently enrolled in Southern Connecticut State University's MSW Co-Occurring Disorders Program and is a certified A-SBIRT trainer. Before we kick off today's event, I'd like to go over two brief polling questions with you. First question we have is, are you familiar with A-SBIRT? Please choose the best response, yes, no, or somewhat. I'll wait a few moments while we look over the responses here. And it looks like from all of our participants, almost all of them are responding that they somewhat are familiar with A-SBIRT. For our next question is, do you work with adolescents or do you work with adults? Please go ahead and select what best describes you. Is it adolescents, adults, or both? All right, and it looks like 100% of our participants are indicating that they work with both adolescents and adults. And with that, I'd like to pass the floor over to Nova.
Good morning. Thank you for joining us today. This is going to be a very brief overview of A-SBIRT. Both Kathleen and I have taken this training, obviously, and you can talk for days about A-SBIRT and what exactly goes into all the components of A-SBIRT and why it is so important. We're just going to talk a little bit about that today, why we use it, and why it is considered a public health intervention. So the acronym A-SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. So let's just dive into each one a little bit. First, it's important to note that A-SBIRT is a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those at risk for developing such disorders. It provides an opportunity for early intervention with at-risk substance users before more serious consequences occur, aka early intervention. And A-SBIRT can be used in a variety of settings: primary care centers, hospital emergency rooms, school counseling centers, youth centers, trauma centers, and I'm sure many more settings. So the acronym, again, the S in A-SBIRT stands for screening, which is a method for identifying an individual who is at risk for substance use. There are various screening tools available for this, which we will discuss a little more in depth later. The BI in A-SBIRT stands for brief intervention, which is a low-intensity, short-duration conversation with those who screen positive. So we will talk more about what we do with those who screen negative for substance use, but for those who screen positive, we do a brief intervention, which builds commitment to change through motivational interviewing, which is a collaborative conversation between the professional and the client, which is the teenager in this case. The goal is to elicit and enhance motivation for behavior change, not to force or punish the individual. And the brief intervention should be conducted immediately following the screening. Okay, and the RT in A-SBIRT stands for referral to treatment. So this is in the case of an individual who shows signs of a more serious substance misuse or use disorder. So a referral to treatment could be for counseling, outpatient treatment, rehabilitation, etc. SAMHSA defines a comprehensive A-SBIRT model to also include the following characteristics. So it is brief, typically about 5 to 10 minutes, or 5 to 10 minutes for the brief intervention. So about 12 minutes in total. The screening is universal, so we do not pick and choose who we screen based on how they look or what we assume. We want to screen everybody. One or more specific behaviors related to risky alcohol and drug use are targeted. The services occur in a public health non-substance abuse treatment setting. The A-SBIRT model should be comprehensive, comprised of screening, brief intervention, and referral to treatment, and it should be backed by strong research and experiential evidence to support its effectiveness. So why is A-SBIRT important? We want to reduce the harms and societal costs associated with substance use disorders, and as you probably know, substance misuse leads to death, over 100,000 preventable deaths each year. It costs $600 billion to society annually, has far-reaching implications on the individual, family, workplace, school, community, and healthcare system. Problems include, but probably are not limited to, employment and school attendance and performance declining, strained relationships and decreased social participation, legal issues, unwanted, unplanned, and unprotected sexual activity, memory and attention problems, adverse effects on maturation of reproductive system, changes in brain development, which may have lifelong effects, and death from alcohol poisoning or overdose, which we obviously don't want to see. And just to really stress why substance use especially is consequential in adolescence, just a little bit of brain facts, the amygdala, which is responsible for our emotions and registering pleasure and pain, develops rapidly in middle childhood and into early adolescence. This is around the same time we see development of the nucleus accumbens, which gives us the desire to engage in activities we find pleasurable. But the prefrontal cortex, which is responsible for planning, organizing, and impulse control, doesn't fully develop until about 25, 26, which I'm even younger than that, so I have not fully developed yet. Essentially, teenagers have a fully functioning gas pedal with no brakes. They're able to decide what makes them happy, what gives them pleasure, but they can't yet weigh immediate rewards with long-term rewards. This can contribute to risk-taking behaviors and feeling like you're invincible, which we often hear with teenagers. So, screening. The first step of the A-SBIRT approach determines the severity and risk level of an individual's substance use. And like I said earlier, we want to make sure we're asking everyone, because if we don't ask, we don't know. We can't just assume by looking at somebody whether they use substances or not. And the screening utilizes either the S2BI, which is a screening assessing tobacco, alcohol, and marijuana use over the last year. It's a two-part screening, which Kathleen will talk more about later on. Or you can use the CRAFT model, which sometimes you would use with the S2BI to get additional information about the teens' behaviors and just their thoughts. The screening does not diagnose a substance use disorder. It uses minimal staff patient time. It determines whether a brief intervention is needed, and it provides valid self-reported information that can be used for feedback, and it often gives the individual a chance to reflect on their own substance use and their own responses. Okay. So this is specifically about alcohol use, the likelihood of a teen screening positive. So 70% of teens screened for alcohol use are low-risk drinkers. So if we screen someone and they're at a low risk, we would reinforce the positive screen, tell them they're doing a good job by not drinking or drinking very little, and maybe provide information regarding hazards of increased substance use. 25% screen as risky drinkers, which in that case we would want to intervene provide clients with information about the risks of substance use and advise to decrease consumption. And obviously, if a teenager is screening as alcohol dependent, which in most cases very few individuals are referred to treatment or screen with alcohol dependence, but if they do, we want to set up a clear process for follow-up, maybe include referral to treatment. And with adolescents, really any substance use is risky because they're still developing, but we want to keep in mind that this model is a harm reduction model and not an abstinence model, so we're trying to get them to have the motivation to change their behavior in some way, but not necessarily to get them to stop entirely all at once. Well, that was fast. So Kathleen is going to talk more about the S2BI model for screening.
Thank you very much, Nova. Hi, everybody. Kathleen here. Next slide, please. So S2BI is a combined screening to brief intervention tool that assesses tobacco, alcohol, and marijuana use over the past year. It has two parts addressing additional drug use as indicated by the first part. For adolescents, the CRAFT is a behavioral health screening tool for use with children under the age of 21 and is recommended by the American Academy of Pediatrics Committee on Substance Abuse for use with adolescents. Previously, CRAFT was the recommended screening tool with 3 opening questions administered first. Newer research has allowed us to replace the opening questions and simplify the A-SBIRT algorithm because the S2BI can screen and distinguish between risk groups more quickly and easily than the CRAFT. We will describe the CRAFT tool after the S2BI. Just a little reminder, when doing a screening, question as written, stay on script. This is research-based. So the following questions, part 1, the following questions ask about your drug use, if any, of alcohol, tobacco, and other drugs. Please answer every question by checking the box next to your choice. In the past year, how many times have you used tobacco? Never, once or twice, monthly, weekly, or more. That question is asked for alcohol and marijuana as well. If the answer is no for all 3 of them, that is the end of the S-SBIRT. The screening is over. There's no need for an intervention. Positive reinforcement is given, and you see the client the next time, the adolescent the next time you see them. If there is any part that's answered 1, you move on to part 2.
Next slide, please.
There we go. Part 2. In the past year, again, how many times have you used prescription drugs not prescribed to you, like pain medications like Adderall? And this is not prescribed to you or also used in a way that it is not prescribed to be used. Never once or twice, monthly, weekly, or more. And the same questions go for inhalants such as nitrous oxide, illegal drugs such as cocaine or ecstasy, or herbs or synthetic drugs such as salvia, K2, or bath salts. So through the screening, part 1 and part 2, if there is no substance use in the past year, you provide positive reinforcement. If there's substance use once or twice in the past year, there will be brief advice given. If it's monthly, the brief intervention will be done, which assesses for problems, advice to quit, a plan to reduce use and risky behavior. And if substance use turns out to be weekly or more, the brief intervention will assess for problems and make a plan to reduce and a referral to treatment. So if your practice already uses the opening questions and the CRAFT as a standard protocol, you will continue to do so. It is both a screening tool and a brief assessment instrument. This CRAFT has screen-like properties. Adolescents who answer yes to 2 or more CRAFT questions are very likely to have a substance use disorder. It is useful to gather more information that will be used in a brief intervention as well. So the questions in CRAFT. C, have you ever ridden in a car driven by someone, including you, who was high or had been using drugs or alcohol? R, do you ever use drugs or alcohol to relax, feel better about yourself, or fit in? A, do you ever use alcohol or drugs while you're by yourself, while you're alone? F, do your family or friends ever tell you that you should cut down on your drinking or drugs? F, do you ever forget things that you did while using alcohol or drugs? And T, have you ever gotten into trouble while using or because of using alcohol or drugs? The term brief intervention refers to any time-limited effort to provide information or advice, increase motivation to avoid substance use, or to teach behavioral change skills that will reduce substance use as well as the chances of negative consequences. So as mentioned before by Nova, a brief intervention is a short, structured conversation with an individual who screens positive for substance misuse. Brief intervention builds commitment to change through motivational interviewing. By weighing the pros and cons of behavior in light of goals and values, it supports change by helping individuals design change plans and provides advice about substance use limits. And it says here it's typically conducted immediately following. We recommend immediately doing a brief intervention after the screening if it is indicated by the screen. The A-SBIRT brief intervention is founded on the principles of motivational interviewing and the stages of change. Helping people change involves increasing their awareness, and change might be important for them. Their awareness that change might be important for them, and then assisting them to move through the changes. And this is done by trying to see things from their point of view and involves setting goals that the client sees as meeting their needs. The engagement should be primary focus with adolescents. Developmentally, as Nova said, teens are struggling to understand themselves and to be understood. And it is challenging to cultivate change in a sea of changes they're experiencing in adolescence. So we're going to go through there's 6 steps in the brief intervention. The first is to build rapport. That is to engage with the adolescent, and you ask permission. We're going to talk about that often. You're asking permission. This is their goals, their change, and we want to make sure they want to answer us and speak with us. While you're building rapport, you will explore substance use. That will draw on the answers from the craft screen, and you want to explore their values. And some of the things we might ask is, before we start, I'd like to know a little bit more about you. Would you mind telling me a little bit about yourself? What is a typical day like for you? How are weekdays different than weekends? What are the most important things in your life right now? Step 2 is weigh the pros and cons. So remember to reflect and summarize this back to the client. There are pros about using alcohol and drugs, and there are cons, and we want the client to put that in their own words. So you may say, I'd like to understand more about your use of this substance. What do you enjoy about it? What else? What do you enjoy less about your use of it? If there are no cons about it, explore different problems that they may have mentioned in the craft. If they had gotten in trouble, if they'd forgotten things, if their friend or families were worried about them. You could say, you mentioned that your mother was upset with you, or your teacher, you didn't hand in your assignment. Could you tell me more about that situation? Step 3, feedback and information. So again, you're going to ask permission. I have some information for you. Can I share it with you? You'll provide the information, provide clear advice to quit, and ask for their thoughts about what you told them. So examples of some things you might say, I have some information about marijuana. Would you mind if I shared it with you? We know that marijuana use can cause problems with concentration, memory, and problem solving. The health effects are also similar to smoking cigarettes, include breathing problems and increased risk for asthma. My advice for you is to stop using. However, the decision to quit is really up to you. What are your thoughts about this information? So you're providing the information, your advice to quit, and asking them what they think about it, because the choice is theirs. Step 4 is the readiness ruler. So you're using a readiness scale. You'll be reinforcing positives, and you help to envision change. So using a visualization and literally having this printed out, laminated, pulling out a real ruler to judge. You're not only saying the words, but you're actually seeing it. So an adolescent can learn this, what they want, by hearing it, hearing themselves say it, and by a visualization. So it reinforces what they're learning. So you could say, to help me better understand how you feel about making a change in your use of marijuana, show them the ruler, and then on a scale of 0 to 10, how ready are you to change any aspect related to your use of marijuana? They'll give you a number, and no matter what number they give you, let's say it's a 5, that's great. That means that you're 50% ready to make a change. Let's talk about what that change would look like. So you reinforce them engaging in a conversation, and then you pick a number below whatever they gave you and say, you gave me a 5, so why not a 2 or a 3? Why not a lower one? That will elicit change talk from the client of why they think they can make this change. And we've got them in a change space right now where they're thinking about this, and now they are speaking about why they want to change. Step 5 is develop an action plan. So in this step, you will elicit ideas from the adolescent, start envisioning the future, explore the challenges. You will definitely draw on past successes. They may have said something with the readiness ruler, well, I think I can change because I've done something in the past which required a commitment to change. You will affirm their ideas, and you'll start to write down an action plan. So certain things that might be said in this step is, what are you willing to do for now to be healthy and safe? What do you want your life to look like down the road? Probe them for goals. Focus on short-term goals rather than long-term goals. How does this change fit where you see yourself in the future? What are some of the challenges to reaching your goal? If you make these changes, how would things be better? And really important, these are great ideas. You want to encourage and reinforce and show your gratitude for them opening up and talking about their future with you. One of the last things you do in this step is ask, is it okay for me to write down your plan? Let me summarize what we've been discussing, and you let me know if there is anything you want to add or change. Step 6 is to summarize. In this step, we are reinforcing resilience and the resources they have, providing any handouts and educational material we might have about different substances. We're going to give them their action plan because it is theirs, it's their words, and we are going to thank them for spending time with us. So again, we'll present a list of resources, ask them which of these services, if any, are you interested in. When you hand them the action plan, here's the action plan that we discussed along with your goals. This is really an agreement between you and yourself. And again, thank you so much for sharing your time with us today. The last component of A-SBIRT is the referral, the RT, referral to treatment. So those who screen positive, and again, that's only about 5% of the people that, the adolescents that you will be meeting with, those who screen positive are referred to outside resources for further assessment, follow-up, and treatment as needed. It does not occur in all cases. You are convincing the client of need for treatment by using the words that they have used to describe their situation. You'll also determine the level of care, so it's good to be familiar about the resources in your area, and based on what you've heard from the adolescent, what level, outpatient, inpatient, if they need residential, if they need detox, medication-assisted treatment. And you'll help them find resources. You want to use your own judgment. You will know when a referral is needed and make the referral before the client or the parent changes their mind. Remember that we are in this change space, and it's really important to leverage that someone is actually thinking about making a change, and try to get them to sign on to the treatment. The keys to the referral is to deliver it as part of the brief intervention. Again, be familiar with the local options. Ask permission to share this information with the parent. And the best chance for a good outcome for treatment is to share with the parent and get them on board with this.
You want to take this part, Kathleen?
Sure. We just have listed here some additional resources from SAMHSA, and the state of Connecticut actually is doing work with this, so that is listed. Any questions you have can be directed to the Director of Education and Training here at the Connecticut Women's Consortium, Shannon Perkins. Her information is listed there. And I believe we do have some questions that have come in, so we will try to answer the things that you have asked us.
Yeah, and just ignore that live training announcement at the top. Although we probably will have another live adolescent A-SBIRT training here at the consortium sometime soon, but that one looks old. So, okay, so we had a nice little comment. Hello, CWC staff. Thank you for this great webinar. You are so welcome. Hope you enjoyed it. So our first question. do adolescents really share honestly? And that is a good question. That's actually a question I had when I took this training. So do you want to talk a little bit on that?
Yeah, I think we're touching on it a little before we started today, Nova and I talking, and the way to, I don't know, secure the most honest answers is to try to talk with an adolescent alone without their parents, if that's at all possible. You want to ensure them that everything will be kept confidential unless there's a acute safety issue, acute risk of safety that you've noticed. Of course, when you're doing a referral to treatment, you will most likely need the parents' involvement for insurance and anything else that's involved there. But for the initial questions, the way I think about it is that people haven't really asked them these questions. And if you really apply the motivational interviewing skills and build rapport, this is a time in life where adolescents are developing their identity. And for someone to ask them what they think about things and to allow them to put it in their words, it develops a sense of autonomy and agency over the decisions. So these are their decisions. This is what you value. These are your goals. So I do believe, I've experienced it, that adolescents do answer honestly. It's based on the interviewer. So that the brief intervention is delivered using motivational interviewing and understanding the stages of change, that, change doesn't always come quickly, or it comes with ambivalence. I think that, yes, you do get honest answers. And also, that there's questions about whether a self-report system is accurate or not. And these screens have been tested. Research shows that you can get highly accurate information using a self-report questionnaire, as long as the interviewer is non-threatening, empathic, sensitive, objective, professional, and that you use a clear, concise, and evidence-based screen. So, yes, I think you can get honest answers.
I couldn't have said it better myself. You pretty much hit everything there. What if the adolescent doesn't want to share anything, was another question.
You want to take that one, Nova?
I don't know if I want to take that one.
I'll take that one.
Yeah.
In general, we often talk when we do this training in a full 4-hour training that change in itself is hard. We get people to think about something that they want to change, and so I guess what was the question? Doesn't want to share anything?
Right.
Well, you can ask them about what they do for their day. I think adolescents want to share, and if they're asked appropriately. So I guess it's, again, sharing honestly, or they're afraid about sharing about change. And I think if we recognize that change is hard to come by, and it's our engagement with them, that's the key thing. It may take a couple sessions to build that up, so it may not be the brief intervention could be 1 or 2 sessions. It may not be the quick 15-minute if they don't want to share, but you're building in a therapeutic alliance. It's not therapy. This is not a therapy, but it is a therapeutic alliance that you're building. And the way I think about it, it's always planting seeds anyway. So if you start asking about substance use, the adolescent may start thinking about it anyway. But anytime you're in an interaction with somebody, a personal interaction, and there's resistance, you want to roll with that resistance if you do want to get some information out of someone. So understand the resistance, and the way you can talk to them is, well, I understand that you don't want to talk about this right now, so what do you want to talk about? And try to understand that, this is tough stuff to talk about, and if asked appropriately, I think you can get them to share. I mean, there's a lot of information on motivational interviewing we could provide. You could reach out to Shannon. We gave that information. It's on the last slide there. We can provide you with some motivational interviewing resources. We provide trainings here on that. But I think this falls upon the questionnaire to provide that environment, a safe, trusting, empowering environment for an adolescent where they can actually say what they want to say. And if they trust you, I think they will share.
When there's a will, there's a way.
Yes, yes.
And when you use it the right way.
And I think we think about changing these kind of things as confrontational. I heard once something known as carefrontational. And it's, breaking through denial is the way we used to think about it. That we we can shame them. And I think if the environment is not one of shaming and not one of confrontation, we provide a place to speak, someone will share with us. And then their own words will help them get into that change space where we are eliciting change talk from them. And it's their goals. And they're able to tell you why they want to do something. When you do the pros and cons and you can ask someone why they want, what benefit they get, whole different thing. And then they can shift to the cons, and now those seeds are planted for future change.
Wow. Great response. Okay, next question. Why don't people screen all the time?
Oh, what do you think, Nova?
For one, I don't think a lot of providers know about it. And that's what makes webinars and trainings like this so valuable, just to get more information in general on what this is and why we do it. Providers will say that they don't have time with their checkups with patients when, in fact, this doesn't take very long at all. So just, again, that education on the model would kind of answer a lot of these questions. Sorry, I'm just reading here. You want to?
Yeah, I think there's also another thing that people don't screen all the time. As Nova said, they don't think they have a good time, but they think of, they don't realize that a screen is quick. You read stuff off a script, it's yes or no, and screening is simply screening in or out the possibility for a problem. And to know that 75% of the people will get positive reinforcement and it'll just be a screen, that's very, like Nova said, it's important to get that information out there. So following the script that's been researched and has an evidence base behind it, yes, no, concise, direct questions, you can screen out this issue very simply. The brief intervention follows afterwards. That's more of the assessment piece where you're actually trying to, find out the level of potential risk that the adolescent is undertaking with their substance use. So I think there's a fear. I have to actually have an interview and have, ask these deeper questions, whereas a screen is very simple and many people will be screened out if the screen is done appropriately. I think that's it.
Right. And there are a couple of questions that were repeats, but I think the last one here is, what if the adolescent doesn't want to change anything?
Oh, I think we answered that one.
We answered
that was
they don't want to share.
Oh, and then
they
don't want to
share
change
and don't want to change anything. Yeah.
Yeah, I think that was. I might have mentioned.
Answered,
yeah, with the stages of change. And I just want to say one more thing about the screening. A lot of providers believe that they can tell when there's a problem, so they don't screen because they think they know. This isn't a knock on providers. This is how we all work, and we think we know things that we don't. We advocate, and A-SBIRT model advocates for a universal use of this. It's a universal screening. We ask everyone. And, 63% of the time, providers correctly identified teens using drugs and alcohol. They were only able to identify a true substance use problem 14% of the time. So I think that's probably the biggest lack of time, and thinking that they know who they need to screen is probably a big problem. I just wanted to get that in there, too, because we did have that statistic for you.
Yeah, and I think with that 5%, it may seem small, but if we can get that 5%, that could be preventing a serious substance use disorder, a death, and just all the collateral damage that goes along with one person. It is like a ripple effect.
Yes.
When one person's life is impacted by substance use. And yeah, so to ask everyone. And
this is a harm reduction model too. So to go back to talking with the adolescents and making sure that not making sure, but dealing with they don't want to share honestly or they don't want to talk about it. Obviously, there are illegal substances. Adolescents, depending on their age, cannot smoke cigarettes. They are underage for drinking. So this is all illegal. but to acknowledge that this is going on, and we know that, and it's harm reduction. Like, do you really know how much this, during the education piece of it, you have a solo cup in your office and the standard drink guide, and say, do you really know how much is in that solo cup? You know, I had one drink because the bottom of the cup didn't get emptied, you know, and they just kept refilling it, so it's just one drink, you know, to let them really know that, you know, the 12 ounces, what that is, how that compares to a shot of alcohol, the different things with the illicit substances, the use of other people, because it was prescribed, it's okay. To let them talk about those things and explain in a harm reduction way that we are planting the seeds for safe use of substances and trying to address a serious substance use disorder that is potentially needs to be referred to treatment. So that's another way, because if you're going into it and you have that mindset when you're talking to an adolescent, they will know and they will be more likely to express change. You are not telling them to quit. They will be telling themselves to quit. You advise them that that is what, you know, the best thing to do, but it is their choice of what they're going to do. So.
Okay. We had a comment, more than a question, just thanking us for this information, and we would just like to thank you guys for being on the webinar today. And I know it was very brief. We talked about a lot, but there is way more to get into with resources and the framework itself, the different questions you can ask. So we would recommend just doing your own research using the resources we provided on this last slide here, and just taking the time to learn even more about A-SBIRT. And I enjoyed doing this today with you, Kathleen.
This is wonderful, and thank you to our providers on the other side putting this technical framework together for us.
I think that concludes Adolescent A-SBIRT.
All right, thank you, ladies. On behalf of CWC, I'd like to thank all of our attendees that joined us today and for all of your great questions. I'd also like to thank Nova and Kathleen again for their great presentation. Thank you again for joining us. This concludes today's event.